It's not Julia.
Yeah, we're good to go.
So she is.
Yep.
Yeah.
Okay.
Right. We're going.
Yep.
Yeah. Order. Bell Ribeiro Addy to move the motion.
Thank you, Ms Furness. It's a pleasure to serve under your chairship. Now, before I get into the crux of this debate, I want to begin by saying this, that the UK is one of the safest countries in the world for a woman to give birth. And I say that at the outset not to diminish the importance of this debate, but to move beyond this platitude, because in the 6th largest economy in the world, this should be one of the safest places to give birth. But I think it's important that we move beyond this and focus on the real and persistent inequalities facing black and ethnic minority women in maternity care. And while I'm sure it's not the intention to focus on this, it can give the impression that because the UK is broadly safe, the negative experiences of some women are exceptional and not matters that require significant government attention. When we detail some of the harrowing experiences of women and hear that response, it can feel as though our concerns are being minimalised. So I hope the Minister will appreciate that I've gotten that part out of the way. Because while the UK is among the safest places to give birth, it's by no means perfect, and for many women it is deadly. As always in this debate, it's vital to lay out the current state of affairs. The disparities in maternity care are not only evident in maternal mortality statistics, which show that black and mixed heritage women are 3 times more likely to die during pregnancy or childbirth than white women, and Asian women are twice as likely, but it is also present in many other areas. Miscarriage rates are 40% higher in black women, and black ethnicity is now regarded as a risk factor for miscarriage. Embrace's 2023 comparison of care for black and white women who have experienced stillbirth or neonatal death found that the majority or significant issues were identified in antenatal care for 83% of black women compared with 69% of white women. 67% of black mothers and babies had a major or significant issue related to pathology, compared to 46% of white mothers and babies, and 75% of black parents and 66% of white parents had significant issues identified during the follow-up or reviews of their and their babies' care. Public Health England's 2020 report found that prematurity is a major cause of long-term infant morbidity. Black mothers, particularly those of black Caribbean background, are twice as likely to give birth before 37 weeks. In 5 Times More's 2022 Black Maternity Experiences Survey, 27% of the 1,340 respondents felt that they received poor or very poor care during pregnancy, labour and postnatally. 42% said the standard of care during childbirth was poor or very poor, and I sincerely hope that the findings of 5 Times More's next survey, which is currently underway, will show some improvement here. According to Bliss, many babies born to black mothers require specialist care after birth, particularly due to preterm birth or full-term complications. Yet significant inequalities persist in neonatal care admissions, the quality of care received and outcomes after discharge. Poor care received at such an early stage of life can have critical consequences and can lead to long-term health complications for black babies and deepen trauma for their families. Postnatal mental health disparities are also significant. UK studies show that women from black, Asian and minority ethnic backgrounds are more likely to suffer from common mental health disorders, yet are less likely to access treatment than... Yeah, I will give way.
I thank the Honourable Member for giving way. The Caribbean and African Health Network report reveals that the prenatal mental health services lack spaces where black women can feel safe, seen and supported. So does my honourable friend and indeed the Minister agree that more inclusive, high quality and personalised care is required to meet the needs of all women in maternity care?
I thank my honourable friend for his intervention, and he's absolutely right. And so I'd like to re-emphasise that point, that black, Asian and minority ethnic women are more likely to suffer from common mental health disorders, yet are less likely to access this treatment. Now, according to Embrace's Saving Lives, Improving Mothers' Care report from last October, deaths from mental health-related causes accounted for 34% of deaths occurring between 6 weeks and a year after the end of pregnancy. It's vitally important that all those who experience pregnancy and childbirth receive mental health support, even if they are not necessarily presenting as struggling with their mental health. But I believe this is especially true for Black, Asian and ethnic minority women who are more likely to have a negative experience during pregnancy and childbirth. Some of the experiences that these women are having are deeply traumatic and scarring and can lead to several mental health problems. Yet despite that, they are less likely to access mental health support, so they are left to try and mentally recover from the experience on their own. This disparity exists beyond pregnancy and childbirth and goes even beyond before conception. According to the Human Fertilisation and Embryology Authority, Black women are 25 times less likely to access fertility treatment. NHS-funded IVF cycles decreased amongst Black patients from 60% in 2019 to 41% in 2021. Black and Asian patients aged 18 to 37 had the lowest IVF success rates compared to white patients in 2020 to 2021, and non-white groups also struggled to access donor eggs, with 89% of egg donors being white, 4% Asian, 3% of mixed heritage, and only 3% Black. During the International Women's Day debate, I highlighted the latest Embrace UK data, which showed a statistically significant increase in the UK's maternal death rate in the years 2020 to 2022, even when excluding deaths caused by COVID-19. Put plainly, more women and babies of all races are dying in the UK now than in the last 2 decades. This is incredibly worrying. So Black women who often face the worst care are likely to experience even further deterioration. Now, when researching the latest statistics and figures for this debate, one of the things that was increasingly apparent is that the data on racial disparities in maternity care is limited and scattered. The data I've cited comes from a collection of reports by various medical bodies and advocacy organisations. Often racial disparities are identified as part of broader studies. As far as I know to date, there has been no comprehensive medical study dedicated exclusively to racial disparities in maternity care and outcomes, despite these consistent statistics that show how bad things are becoming. Now, the Lancet's recent study on maternal mortality and Embraces UK's reports do include racial breakdowns, but they are based on the data that they have, not on the data that they need. But there is no single dedicated study that is yet to be conducted. Now, this lack of comprehensive research makes it incredibly difficult to see a full picture of what's happening. So I hope the Minister will address this point in their response and highlight what the government is doing to get a clearer picture of the state of maternity care. Now, there is no one driver for the racial disparities in maternity care and outcomes. The causes are multifaceted, but overwhelmingly, they are a result of a combination of structural racism, unconscious bias, gaps in culturally competent care, and socio-economic inequalities. The first two are incredibly important to highlight because without acknowledging that the NHS has an issue with institutional racism and unconscious bias, we cannot address this problem. For it is this that is feeding into the quality of care being delivered for Black mothers and their babies. The inaccurate and dog whistle assumptions around Black women and their pain tolerance, for example, which can lead to women being denied pain medication during childbirth or misbelieved when raising concerns of pain felt, which can signal a severe medical condition, are not taught in medical school or during training, yet so many Black women have come across a nurse or a midwife or a doctor that holds that belief. This is a direct result of institutional racism in the NHS and is having a direct impact on the care that women are receiving. On the socio-economic inequalities, I believe it's important to note that while racial disparities in maternity care are experienced regardless of class, occupation, education and geography, this is still a very important factor. We know socio-economic inequalities can be a determinant of health outcomes and experiences. Women living in the most deprived areas have a maternal mortality rate more than twice as high as women living in the least deprived areas. Black and minority ethnic people are 2.5 times more likely to be in relative poverty and 2.2 times more likely to live in deep poverty. So the combination of socio-economic inequalities and institutional racism within the NHS is having a dual impact on Black mothers' experiences of maternity care and their health outcomes. I know that much of the work of the previous government did in its attempts to improve maternity care focused on comorbidities and socio-economic drivers of poor health. And indeed, it's crucial that these areas are addressed, but without looking at the structural racism and unconscious bias in the NHS, the problems will persist. Now, for the remainder of my contribution to this debate, I want to recognise the campaign groups that are pushing this issue up the political agenda. In the absence of concrete government or NHS action, advocacy groups have stepped in, offering their solutions and recommendations, and where they can, offering alternative care and training. First, and always first, I must commend 5 Times More, who established the Black Maternal Health Awareness Week in 2019. Their work empowers black women to make informed decisions during pregnancy and advocates for systemic change. They are currently conducting their second national survey, building on their impactful 2022 research. They're calling for a measurable government target to end racial disparities in maternal deaths, a commitment that the Labour government supports but has yet to implement. I hope the Minister will confirm today whether such a target will be set and how it will be measured and when we can expect it. 5 Times More also advocate for mandatory annual maternity surveys focused on black women's experiences, compulsory anti-racism and cultural competence training for all maternity professionals, and improved data collection on ethnicity and outcomes. Yes, I will.
I want to thank my honourable friend for securing this very important debate, and thank you, for giving way. Given the complexities and interchangeable disparities that are impacting maternal health for black women, does she agree with me that without a national target and without a national framework, we are doomed to continue the same mistakes over and over again, and that this travesty needs to end, because no mother, no child health outcomes should be determined by the colour of their skin?
I thank my honourable friend for her intervention, and she's absolutely right. These figures have been circulating for decades now, and it was only following a very successful parliamentary petition launched by 5 Times More that we first debated them in this House. But this is still a good few years on. I think we're talking 5 or 6 years on, and we're still in this situation. So things absolutely have to change. And you know, I'll continue paying tribute to a lot of the amazing groups that have been pushing for those decades to put this on the agenda. So we also have the Mimosa Midwives. They're another remarkable group that offer culturally safe, continuous maternity care. They campaign for a culturally appropriate care model within the NHS and for inclusive training in midwifery education to reflect diverse maternal experiences, because much of our medical training remains centred on white women. Now, the Motherhood Group is another group. It's a social enterprise supporting black mothers with peer-led services, training workshops and national campaigns. Their annual Black Maternal Health Conference brings together researchers, clinicians and service users to tackle disparities, and they also launched the Black Mums app to connect mothers navigating similar challenges. There are other charities like Bliss, Tommy's, Birthrights and the Royal College of Midwives also highlighting racial disparities in their broader efforts to improve maternity care. And they've done this where the government and NHS have fallen short. They have taken the time, they have campaigned and they have stepped in. However, I do have to acknowledge the positive steps taken by the new government and the NHS. In response to written parliamentary questions I raised last month, the government actually outlined some ongoing measures. Every local maternity system must now publish an equity and equality action plan, setting out tailored actions to reduce disparities, especially for ethnic minority women and those in deprived areas. And I welcome the rollout of the Saving Babies Lives Care Bundle, version 3, which aims to reduce stillbirth, neonatal death, preterm birth and brain injury. The maternal medicine networks are also being established to ensure equitable access to specialist care for women with heightened risk. And these efforts are supported by the NHS Equality, Diversity and Inclusion Improvement Plan, which was launched in 2023. This plan is going to require the NHS organisations to tackle workforce discrimination, improve leadership accountability and foster inclusive and harassment-free environments. I'm also pleased to note that the NHS England is developing a respectful and inclusive maternity care toolkit to support inclusive and culturally competent practice. These are all really welcome developments, but much more is needed. So I'm going to close with 4 questions for the Minister. First, will the government commit to a statutory inquiry into racial disparities in maternity care, including testimony from affected families and frontline providers? Second, will the government fund dedicated research into the medical complications disproportionately affecting black women during pregnancy and childbirth? And Thirdly, will the government commission a review of maternity training across all medical professions to better equip practitioners in recognising complications and symptoms in black women and babies? And finally, does the government acknowledge the presence of systemic racism within the NHS? And if so, what steps are being taken to confront and eliminate it? It's good that in these past few years, the House has taken the time to acknowledge these issues and allow us to come and debate them, and that even that the government has put forward in its manifesto that a target will be set. But now we need to see action. We cannot continue to see these gaping inequalities in maternal outcomes. Thank you.
The question is that this House has considered Black Maternal Health Week 2025. I call on Michelle Welsh.
Thank you, Chair. It's a pleasure to serve under your chairship, and congratulations to my honourable friend, the member for Clapton and Brixton Hill, for securing today's very important debate. My honourable friend has already highlighted that black women often receive a worse standard of care, and a risk of maternal death is 3 times higher than white women. I want to use today as an opportunity to highlight the situation in Nottinghamshire. Why? Because I think it demonstrates why change must happen, and must happen quickly. As some here will know, there is currently an independent review into maternity services at Nottingham University Hospitals Trust, led by Donna Ockenden. I first called for this review when I was a counsellor after my own experience giving birth to my son in 2020. I knew then, as I still do now, that women accessing services at NUH do not always receive the care they deserve, nor are they listened to when they are raised concerns. And so, ahead of today's debate, I reached out to Donna Ockenden and her team for their perspective on black maternal health in Nottinghamshire, so I could highlight that here today. When the Donna Ockenden review, which was only 2 years ago, was established in Nottingham, the Nottingham University Hospitals Trust could not give the review a single named contact within the black community that they could share with the review, nor did the hospital have any meaningful engagement with the many groups that existed across Nottinghamshire. So they had no way of reaching into groups of black women that may have been affected by poor maternity care, no way whatsoever. There were also very limited translated resources provided by the Trust. It is therefore not surprising that the trust between black communities and Nottingham University Hospitals was at an all-time low. And as Donna Ockenden rightly emphasised to me, this only increased the risk that women and their families would disengage from vital health services and would be unable to give informed consent to treatment through their maternity programme. I'm pleased to say that the work that Review has done so far is leading to some improvements within the NHS, and I believe it's important to acknowledge that progress, even if there is still so much further to go. Since the review has begun, Donna and her team have met with many community groups across Nottinghamshire, attended numerous church services and meetings across the majority black-led churches. They've also appeared on the infamous Kemet FM, a local community radio station that focuses on the music, well-being and culture of Nottingham's African and Caribbean communities, and it broadcasts across the East Midlands and the Caribbean. Following this outreach, many black families have come forward to the review, and their community engagement has strengthened over the course of the review's progress. And I'm pleased to report that these learnings are shared with the Trust in a bi-monthly learning and improvement meetings. Although it has taken years to build that relationship with local communities and to establish some trust, it is also not only essential in providing safe care that is reflective of the population's needs, but we have to ensure this happens so the voices of black women are no longer ignored. Following this outreach from the Donna Ockenden review, it was clear to see that for so long there had been little or no communication. And I think what is really, really important in all of this is to acknowledge the fact that not every trust has a Donna Ockenden. They don't have somebody that is reaching out to black communities and black women to find out what is happening and how they are affected by the health services. And so I know for the last 14 years I've had a huge detrimental impact on maternity services across the country. And the only ways we begin to fix them is if we tackle the underlying issues within the culture of the NHS. It is important to note, as I've just said, that not every NHS has a Donna Ockenden and this level of scrutiny that has happened in Nottingham. As the new elected chair of the Maternity APPG, I'm committed to working with the government on a health strategy for maternity services that recognises how inequalities have a huge impact on the care people receive. I would therefore urge the Minister to ensure that in any forthcoming maternity strategy, the experiences of black women are at its heart and the trusts are strongly encouraged to engage with communities so voices are no longer ignored. Inequalities must be addressed. We require a national framework and a maternity strategy that is fit for the future. Thank you.
Next, I've got the Lib Dem spokesperson, Jess Brown-Fuller.
Thank you, Chair. And I'd like to begin by congratulating the member for Clapham and Brixton Hill for securing today's important and timely debate following Black Maternal Health Week earlier this month. Her opening remarks were comprehensive and thoughtful, and I'm always pleased to hear from the Honourable Member for Sherwood Forest, who is a passionate advocate for improved maternity services in Nottingham and across the whole of the UK, and I'm pleased to serve with her on the APPG for maternity services with her at the helm. During pregnancy, women are at their most vulnerable, carrying another human life with them. They deserve the very best care, and they have more touch points with the NHS than they will for most of their life. We engage with the NHS when we are born, we engage with the NHS when we need to access social care at the end of our lives, and when we are carrying a child, you have more moments in front of medical professionals than you will for the majority of your life. But the Care Quality Commission, following inspections of 131 maternity units, found that 65% of units were not safe for women to give birth in. 47% of trusts require improvement on safety, and a further 18% were rated inadequate. The Commission warned that it is concerned about the potential normalising of serious harm in maternity care, and these risks are particularly stark for women of colour in this country, for whom pregnancy continues to carry an unacceptable level of danger. And as the DARSI report highlighted, black women are almost 3 times as likely as white women to die during childbirth, while neonatal mortality among the most deprived quintile is more than double that among the least deprived. That is nothing less than a national scandal. Maternity care is an issue close to my heart, having had 2 very different experiences giving birth in my local hospital in Chichester. I tabled an early day motion on maternity care and secured a backbench business debate in this chamber on that very subject just 2 months ago. Like the member for Sherwood Forest, I'm in regular contact with Donna Ockenden, who produced the Ockenden report. Her findings, along with those of Dr Bill Kirkup, show that the problems identified at trusts in Shrewsbury, Telford and East Kent are not isolated incidents. The same issues are systematic and widespread across many NHS trusts up and down the country. And in preparation for the previous debate on maternity services as a whole, I spoke to families across the country who had experienced devastating failures in the system, families who went into hospital expecting a joyful outcome and to go home with their child, and instead had to go home without their babies, living with the trauma of that experience, which they carry with them for the rest of their lives. And as the Honourable Member mentioned, the latest Embrace report for 2021 to 2023 confirms that inequalities in maternal mortality rates persist, with a nearly 3-fold difference among women from black ethnic backgrounds and an almost 2-fold difference among women from Asian ethnic backgrounds compared to white women. Women living in the most deprived areas continue to experience maternal mortality rates twice that of those in the least deprived areas. And care for black women who experience stillbirths or neonatal deaths is often inadequate, and ethnicity is still not routinely recognised as a risk factor, for example, in screening and prevention of conditions such as gestational diabetes. Births to black mothers are almost twice as likely to be investigated for NHS safety failings. and black mothers are twice as likely to suffer from perinatal mental illness compared to their white counterparts. I pay tribute to my honourable friend, the member for Twickenham, who has long been talking about these disparities, and she introduced the Miscarriage and Stillbirth Black and Asian Women Bill in 2022, seeking to require the Secretary of State to lay annual reports before Parliament on efforts to reduce miscarriage and stillbirth rates among black and Asian women, which unfortunately wasn't carried over into the next Parliament. And it is also worth reflecting when so many of our conversations in this chamber and in the other place are about the economic pressure that we as a country are in, that on top of the enormous human toll, there is also a financial cost to failure, because obstetric claims make up just 13% of clinical negligence cases handled by NHS resolution, but they account for over 1 billion a year, nearly 60% of the total cost. Across the country, families face unbearable grief and trauma because of the failures in maternity care, and this burden is falling disproportionately on black women and families. We as Liberal Democrats are committed to transforming maternity services to make the UK the safest place in the world to have a baby, and we fully support the work of Black Maternal Health Week in drawing attention to these critical issues. Our manifesto in the general election pledged to revolutionise perinatal mental health support, not only for those currently pregnant and new mothers, but also for those who have endured miscarriage or stillbirth. And we have been clear that the government must, as a priority of the highest urgency, implement all of the immediate and essential actions recommended by the Ockenden report. It is deeply concerning, even years after the tragedies that we saw at trusts in Shrewsbury, Telford and East Kent, that failures are still widespread and efforts to address them appear piecemeal. When my honourable friend, the member for North Shropshire, questioned the department on the implementation of the Ockenden recommendations recently, it was alarming that the department could not confirm whether actions had been implemented, nor did it appear to have a system for centrally monitoring the progress. Although in their reply, the Minister pointed to the 3-year delivery plan for maternity and neonatal services as its main response, deeper analysis shows serious shortcomings. Many measures in the plan have no meaningful numerical targets, making real accountability as to the difference it's making very hard to track. Targets for expanding access to perinatal mental health support are being missed, even as some improvement is noted. And staff satisfaction indicators remain worryingly low, with some measures still recording fewer than half of the staff in trust expressing confidence in educational opportunities or in their management's response to unsafe practices. The target set in 2010 to halve maternal mortality looks increasingly out of reach. Maternal mortality rates did not fall for a decade, and between 2021 and 2023 they actually increased. And worse still, no updated data has been published for the last 2 years on the rates of serious brain injury, stillbirth, neonatal mortality or preterm birth. Without transparency and accountability, women will continue to be failed, and black women who already bear the brunt of the disparities will continue to be disproportionately harmed. And this is why I asked the Minister today to commit to urgently reviewing these issues and to meet with me and my colleagues from the Liberal Democrat Health Team to discuss a more effective plan to improve maternity safety and set out a clear path to address the deep disparities in black maternal health. Alongside this, the Liberal Democrats are calling for a cross-government strategy led by the Department of Health and Social Care with annual progress reports on reducing miscarriage and stillbirth rates among ethnic minorities. We also call for increased funding for public health initiatives with a portion earmarked for communities facing the worst health inequalities, allowing them to co-produce solutions which are tailored to their specific needs. We propose the creation of a health creation unit in the Cabinet Office to lead work across government to improve health and tackle inequalities. Madam Chair, black women have waited too long for their concerns to be heard, for the system to change and for justice to be done. We owe it to them and to every woman in this country, every family and every baby to get maternity services right. No woman should fear for her life or her child's life because of the colour of her skin or the postcode that she lives in. We have to do better. Thank you.
Opposition spokesperson Caroline Johnson.
Thank you, Ms Furness, and it's a pleasure to serve under your chairmanship. I'd also like to congratulate the Honourable Member for Clapham and Brixton Hill for securing this important debate today. As she said in her opening speech, the UK does enjoy some of the best outcomes in the world when it comes to maternity health, but there is always more work to be done to improve our outcomes further. And I hope we can all agree that equal access to the best care for all across society should always be our target. This should be based on excellence across the board as standard. It is Black Maternal Health Week and indeed the broader National Minority Health Month of which it's a part, and I welcome this opportunity to discuss the topic and exchange views with colleagues across the House. Colleagues will know that as a clinician myself, I'm always guided by data when assessing current healthcare practices and new policy proposals. A 2023 report by the Maternal, Newborn and Infant Clinical Outcome Review Programme found that from 2019 to 2021, 241 UK women died during pregnancy or up to 6 weeks after the end of pregnancy. That equates to a rate of 11.7 women per 100,000 giving birth. Each of these cases represents a tragedy for the women involved, for their babies, for their families and for their loved ones. And we must do all we can to prevent them. The data does, as has been mentioned, also show that women from black backgrounds face a mortality rate much higher than the average, equal to 37.2 per 100,000. And women from Asian backgrounds also see a higher rate, at 17.6 per 100,000. Clearly, these figures represent a pretty stark picture, and we must exercise care in the interventions that we make and balance our desire to resolve the problem with ensuring that we do it in a way that does resolve the problem and doesn't risk creating others. At the outset, it's crucial to ask, what is the government doing to understand the specific causes of these outcome disparities? Because if we understand the causes, then we'll better be able to manage and treat them. The Kirkup reports and Ockenden reports have been already mentioned. And what is the government doing to ensure that those recommendations are fully implemented? And what is it doing looking forwards to develop a strategy to ensure that all women have a safe opportunity in pregnancy and birth? What kinds of data do the NHS and the Department of Health and Social Care hold which might cast a light on other demographic, economic or geographical patterns which contribute to these numbers and which we may be able to help to resolve? We know that the most significant factor in predicting death during the maternity period is a pre-existing medical condition. And we do know that disparities exist in the incidence of some pre-existing conditions which are relevant between some ethnic groups in the wider population. For example, a 2018 research paper in the American Journal of Kidney Diseases found the rates of heart disease were 20% higher among the black community than those from white backgrounds, and rates of stroke a remarkable 40% higher. So does the government know how these rates of pre-existing conditions among ethnic groups are influencing the figures on maternal health? And how is it going to work to reduce the risks of such conditions among these groups to try and improve not just the care during maternity, but the care during the whole of the black ladies' or ethnic minority ladies' life? Maternal mortality itself arises from a number of different conditions and causes. In the 2019 to 21 period, for example, 14% of maternal deaths were attributed to cardiac disease, 14% to blood clots, 10% to sepsis, and 9% to epilepsy or stroke. So what is the government doing to understand the prevalence of these conditions among other ethnic groups, to understand how these conditions can be prevented, how they can be identified in black women and indeed in all women, and how they can be better treated to save lives, how they can be managed to save lives, and what research can be done to ensure that these conditions, if possible, can be prevented. Deprivation, socioeconomic deprivation, has also been mentioned. It's important to consider the impact of deprivation. 12% of women who died during pregnancy or in the year afterwards, from 2019 to 21, were at severe and multiple disadvantage, particularly women who suffered mental health conditions, domestic abuse or a history of substance abuse. So how does the government understand these factors and their influence on mortality rates? And what is it doing to help resolve those issues? Closer to home, the NHS Race and Health Observatory published the Ethnic Equalities in Healthcare, a rapid evidence review in February 2022. The authors of that report noted that tackling poorer care and outcomes among ethnic minority women and babies continues to be a focus within NHS England and NHS Improvement Maternity Transformation Programme Equity Strategy. and that includes pledges to improve equity for mothers and babies and race equality for staff. The NHS England now being abolished by this government does risk placing this ongoing programme of work, like many others, in jeopardy. So can the Minister tell us the current status of the maternity transformation programme, the implementation of its equity strategy under NHSE and DHSE reorganisation? How is this work being prioritised amongst the many other demands now being placed on time and resources within the department, not least the time and resources being spent on reorganisation that may previously have been spent on improving care? The previous government increased the number of midwives per baby when compared to previous levels. We also made progress towards the national maternity safety ambition, aiming to halve the 2010 rate of stillbirths, neonatal and maternal deaths and brain injuries in newborn babies. When will this government set out its ambition for the next decade? The Labour government promised over 1,000 new midwives in the manifesto last year. Can the Minister update us on how many of those 1,000 midwives are now working for the NHS? The Minister of Care also stated recently that the 41 maternal mental health services are now live and will be active in every ICS by the end of 25-26. How will the government enable access to these services to continue while ICSs themselves face such high cuts in funding? Colleagues have also mentioned the possibility of the influence of systemic racism or unconscious bias in maternal outcomes. Within a population or an employed population of 1 million people, it is likely that you will find some bad apples amongst a overwhelmingly brilliant NHS staff cohort. But I would dispute that the NHS overall is a racist organisation. I work in the NHS, I should declare an interest in that, but I've not seen evidence of structural racism. The Royal College of Obstetrics and Gynaecologists reported that of 2024, 45% of obstetric and gynaecological doctors identify as black, Asian or minority ethnic background, and 26% of births were to women of black or other minority ethnic backgrounds. Figures for midwives are harder to ascertain because they're collated with nursing staff, but again the proportion is 22% amongst nurses who are described as black. I will give way, yes.
And I just wanted to check if she understood that structural racism is not about numbers of people within an organisation. It's about the way the organisation is set up and how it treats different people because of its basis of its founding. And does she understand that having a high proportion of ethnic minority people does not necessarily mean that an organisation that, like the NHS that I might add, that in its senior levels are mostly run by people who are not from ethnic minorities, will not discriminate against people in a certain way?
I understand the point that the Honourable Lady is making. The point that I'm making is that I don't dispute that some women will have awful, or men or boys or children will have awful experiences at the hands of bad apples when they're in any organisation of the size that employs over 1 million people, which is wrong and should be rooted out and should stop. That's absolutely clear. But I work in the National Health Service, and I think the vast majority, the very, very vast majority of people who go to work in a health service do so to care as best they possibly can for the patients that are in front of them. And when delivering care, care should be provided on the basis of clinical need, not on ability to pay, and not on any other socioeconomic or ethnic or any other demographic data. And it's from what, whilst I accept the Honourable Lady's point that some individuals may have experienced poor care, and some will have experienced poor care, and that is reprehensible, I don't think that is the majority situation by quite some margin. I think most people receive extremely good care in the NHS, and I think most people receive care that is delivered on the basis of their clinical need and not on the colour of their skin. Yes, well.
Thank you for giving way. Does she also accept that she's not really in a position as somebody who is not of an ethnic minority or who has not looked at the information given by a number of women who are from ethnic minority backgrounds who have experienced this, to then go on and comment that what they've said they've experienced doesn't exist? By stating what she... No, well, I'm just challenging her point that just because she may, for or 2 reasons not have seen any institutional racism in the NHS does not mean that it doesn't exist. Further to this, the figures for black maternal mortality are actually the same in the United States, which has a completely different healthcare system from us, and they are not the same in countries in Africa or the Caribbean, where black women are, and you know, that black women are the majority. So by that understanding, does she see why it can only point to institutional racism? It's a completely different healthcare system in the United States. The only difference is we are both living in societies where institutional racism is known to be a problem.
I think we can both agree that any examples of racism are reprehensible and should be rooted out. I think we can both agree that the examples given by the people who speak them are speaking of their perceptions and what they have experienced in a truthful fashion, and that no one is denying the experiences of individuals or even groups of individuals who've experienced poor care, and that poor care should stop. I just don't think that represents the suggestion that the NHS itself is a racist organisation, because I don't believe that it is. And that's a point of difference. I think the staff that work in the NHS are overwhelmingly not racist people, and overwhelmingly people who want to care for people on the basis of the need that they present with clinically to the very best of their ability, regardless of any ethnic minority status.
I'd just like to make one.
Yeah, she can come back in the end.
I did not say that the people in the NHS are racist. I said the NHS has a problem with institutional racism, and I hope the Honourable Member will accept that there are distinctions between those 2 points.
I think we've both made our statements clear. I accept that some people will have received care that is poor standard, and then those people who deliver those care need hauling of the coals in compartments. You know, they need to be called out for what they have done and made sure that this sort of care does not happen again in the future. But I don't accept the NHS as a racist organisation. Rapid review of, just to look at another issue, which is the language barriers. It's difficult for people who have a language barrier to access health services. That's something that's well recognised. And I'm interested to hear from the Minister what the government is doing to help with that. In recent years, during my medical career, I have seen improvements in the delivery of language services. When I was a more junior doctor, it was required to book an appointment in advance. The interpreter had to come in person. Sometimes they were available, sometimes they weren't. Sometimes other members of staff or even indeed other members of the family would be used to interpret, which is a poor standard of care, relatively speaking. I will give way, yeah.
I wonder if it would be possible for you to perhaps highlight what NHS you're actually working in, because the experiences and the reports nationally with regards to interpretation and translations are very, very different to what you're saying today. They don't reflect the factual accounts what are going in, and certainly do not reflect what has been happening in Nottinghamshire.
Okay, I did my junior part of my medical career in Nottinghamshire, and I'm describing what happened in the junior part of my career, which is actually about 20 years ago now. So 20 years ago, that my experience of the situation was that it was very difficult to get interpreters, and that people were used to interpret which were not the appropriate people, and they were not proper interpreters, and then that shouldn't be happening. What we've seen over time is that the service is still not perfect, but translation services have improved, and many hospitals have instituted new iPad systems where one chooses the country of origin or the language that the person speaks on the iPad, and then a sort of a working from home dial-up system is used to provide an interpreting system, which is much better because it is more available to the patient than the services we had in the past, which required someone in person. But it's still not perfect, and we still see areas across the country where those services are not available and interpretation is still unavailable to people. So I'm interested in the Minister understanding from the Minister how the Minister is going to ensure that women who do have difficulties with the English language are able to access interpreters when they need them, and not just when there's a booked appointment, but actually also when there is an out-of-hours emergency, because I think that's when interpreters are most difficult to obtain. And particularly for languages which are spoken by a fewer number of people within the United Kingdom. And then I wanted to ask about the government's plans going forward. So there was the previous government instituted a 3-year plan which comes to an end next year. When will the government produce their plan? They've talked about their 10-year NHS plan, They said they would produce that in the spring, I believe. We are in the spring. When looks outside, it's a beautiful day. The flowers are out. The lambs have been born. Where is this plan that the government have promised? And what targets are they going to set and when to improve maternity care for all women and for black women specifically? Thank you.
Respond.
Thank you. Ms Furnish, Mrs Furnish?
Whatever you like.
Mrs Furnish. Whichever, it is a pleasure to serve under your chairmanship. Madam Chair, tackling inequalities... go back to it. Right, again. Before I begin, I first want to thank the Honourable Member for Clapham and Brixton Hill for securing this important debate during Black Maternal Health Awareness Week. It is so important that we raise awareness about the disproportionate challenges faced by black mothers during pregnancy and after childbirth. And debates in weeks such as this are critical to that. I want to pay tribute to the charities who do so much vital work in this space. The Motherhood Group, 5 Times More, Black Mums Up Front, which is part of Bliss, and Ebony Bonds, to name just a few. I'm taking this debate on behalf of the Minister for Women's Health and Patient Safety, Baroness Merrin, and I also want to thank all members for their contributions to this debate today. I will seek to pick up and answer all of your queries. If you feel at the end of the debate that I haven't, please, if honourable members can get in touch, then I will make sure that we respond to honourable members that way. I want to thank the charity SANS for shining a spotlight on some of the most heartbreaking cases of baby loss in the UK and for giving a voice to so many black and Asian women who have gone through the nightmare of losing a child. One such case was Amber Lincoln from Woolwich in south-east London. She was miscategorised as low risk when she was pregnant, and she nearly died from undetected complications after her delivery. A series of individual and systemic failings led to cancellations and delays, and her twins, Anaya and Mael, were born and died at 22 weeks in November 2022, before she could access the care that she needed. Amber said, and I quote, "If the NHS had just listened to me and just put my appointment through when I was constantly asking, if they had the notes there properly, I wouldn't have been treated that way." Amber said the fact that she's mixed race led midwives to focus on diabetes and high blood pressure rather than other high-risk indicators. And I wish I could stand here and say that Amber was an isolated case, Madam Chair. But her story will sound familiar to black women up and down the country, and it shows in the figures. The latest data from Embrace UK shows maternal mortality rates for women from black ethnic backgrounds are more than double those for white women. Black women and their babies are also at higher risk of stillbirth, neonatal death and miscarriage. This should shame us in modern Britain. So, Madam Chair, tackling inequalities and racism in maternity services is an absolute priority for this government. Our manifesto committed to setting an explicit target to close the black and Asian maternal mortality gaps. This commitment has not wavered. We are working hard to not only set a target, but also to set the actions that will help deliver it. It's crucial that we set the right targets and ensure the system is supported to achieve any target set. And it's why the government is currently considering the action needed that will drive change on the ground, ensuring that targets that are set are evidence-based and that they are women and baby-centred. Our ambition is not to just improve maternal outcomes. We want to improve black women's experiences of maternity care too. We know that too often black women are not listened to and experience racism and bias. This is completely unacceptable. Importantly, our ambition must also extend beyond maternity services so that we can tackle wider health inequalities, including the determinants of ill health. I know that health inequalities do not start at the door of maternity services, and nor do they end when women go home. So here is what we're doing and where we need to go further.
We are aware of calls for a national inquiry into maternity care, which we will carefully consider. There have been a number of reviews, inquiries and wider research in recent years that have provided a shared and clear sense of the issues within maternity and neonatal care. The most important priority must remain for us to target resources and efforts to address the existing issues identified and avoid any further delays. The focus must be to address inequalities and the action taken to do so for women and babies. NHS England are now in their final year of delivering their 3-year plan to improve maternity and neonatal services. Central to this plan is the objective to reduce inequalities for all in maternity access, experience and outcomes, and taking steps to tackle and address inequalities for black women. To do this, all local areas now have in place and are implementing their equity and equality action plans. These plans detail local interventions tailored to population needs to tackle inequalities for women and babies from ethnic minorities and those living in the most deprived areas. There have been some great examples of local best practice within these plans. This ranges from targeted preconception health support, tailored support to ensure equitable access to care, and bespoke communications for pregnant asylum seekers and refugees. As part of the 3-year delivery plan, all local areas are working to implement version 3 of the Saving Babies' Lives Care Bundle. This provides maternity units with guidance and interventions to reduce and tackle the inequalities within stillbirths, neonatal death, brain injury and preterm birth. These local and national interventions are essential steps to improving equity and equality in maternity care. But in parallel, it is vital that we continue to work to foster a culture of safety, compassion, honesty, and one that is actively anti-racist. This must be led by outstanding leadership. I'm pleased that all 150 maternity and neonatal units in England have signed up to the Perinatal Culture and Leadership programme. And for clarity, I think particularly for the Shadow Minister, we recognise that racism and unconscious bias needs to be tackled, that it is unacceptable and must be tackled in the NHS. I will finish what I'm going to say and then I will give her an opportunity to come back to me. To clarify, it is not only about the behaviours that we must tackle in the NHS, it is about the systems that we create in the NHS and ensuring that those systems do not consciously or subconsciously discriminate against people on the grounds of their race. That is what we mean, and that is why we're putting in place training for those leaders in our maternity units to ensure that they are signed up to the Perinatal Culture and Leadership programme to ensure that those systems are as equitable as they possibly can be, and I'm happy to give way.
Racism is wrong and must be weeded out wherever it happens. Could she say, in answer to the question that was posed by the member for Clapham and Brixton at the beginning of her speech, does she believe that the NHS is structurally racist?
The Shadow Minister will know that that is not actually the question that the member asked. The member asked about systemic racism. We recognise that racism and unconscious bias can play a part both in the behaviours of some people, and that must be tackled, but also in the way that systems are structured. And that is why the training that we're bringing forward will help tackle that. It is not necessarily the case throughout the NHS, but we must do everything we possibly can to make sure that those systems are as equitable as they can be, and I'm going to make some progress. I will.
Thank you. I confess I thought I'd heard the honourable member say structural, but if it was systemic, does the Minister think the NHS is systemically racist?
I think that we have to do everything possible to make sure that all of the systems in the NHS are as equitable as possible. We've set clear expectations for the escalation and accountability through the 3-year plan, because all 150 maternity and neonatal units in England have signed up to the Perinatal Culture and Leadership programme. We're supporting staff to hold up their hands when things go wrong through the Freedom to Speak Up initiative. And our approach to tackling inequalities in maternity and neonatal care must be underpinned by evidence, research and, critically, working with women and their families. As the Honourable Member for Sherwood Forest pointed out, it is crucial that women's voices and black women's voices are heard. In terms of funding research, which the member that brought the debate raised in the debate, the NIHR has launched a £500 million funding call, challenging researchers and policymakers to come up with new ways of tackling maternity inequalities and poor pregnancy outcomes. The NIHR has also invited applications with funding up to £500,000 for a research project to understand how biases in medical devices used during the pregnancy and neonatal period might be contributing to inequalities for women and babies. NHSE are also working closely with the Race Health Observatory on the outputs of the Learning Action Network programme, which aims to address the inequalities for women and babies from Black, Asian and other ethnic minority backgrounds. Local maternity and neonatal voices partnerships bring together the voices and experiences of women and families to improve maternity and neonatal care. More than a quarter of these partnerships leads are from ethnic minority groups. Women's voices must continue to be at the heart of our improvements to care. But, Madam Chair, I will be frank with colleagues that while these measures I've just set out are important, I do not believe they will be enough to meet the scale of our ambitions. This government is committed to ensure that all women and babies, regardless of their ethnicity, background or location, receive the high-quality, equitable care that they deserve. Many of these initiatives began under the previous government, and whilst there's been some progress across maternity and neonatal care, for example, good progress has been made in reducing the number of stillbirths and neonatal deaths, we've much, much further to go to improve care and tackle inequalities. So looking forward, we're clear we want to see high-impact actions to tackle inequalities and racism in maternity services. Baroness Merron and the Secretary of State are working closely across the sector to identify the right actions and interventions that will deliver the required change. The Shadow Minister asked about data collection, and data on women's ethnic background is routinely collected by services at multiple points throughout maternity care. This data is used to disaggregate reporting of adverse outcomes like maternal mortality by ethnicity, and differences by ethnicity are also reported as part of the Care Quality Commission's annual survey, which asks a sample of pregnant women and new mothers about their experiences of NHS service maternity services. NHS trusts are incentivised to collect this information through the Maternity Incentive Scheme, which is a financial incentive programme designed to enhance maternity safety within NHS trusts. Safety Action 2 of the Maternity Incentive Scheme incentivises trusts to submit digital information, including ethnicity data, to the maternity services dataset. Some of our processes will take time to implement. But we need to understand the immediate actions that can begin to deliver change here and now. As part of this, I want to again reiterate our commitment to setting an explicit target to close the Black and Asian maternal mortality gaps. We must get this right. Targets must be evidence-based, which is why it's so important that we have the data being collected, as I've just outlined. And our targets must be women and baby-centred, and crucially, the system must be supported to meet the targets set. To support this, the NHS England have undertaken a review of the evidence base and conducted extensive stakeholder engagement to identify the key drivers of inequalities for Black and Asian women and babies, again ensuring that Black women's voices are heard. I'd be happy to give way.
This is giving way. She's talked about the importance of setting an achievable target and working on how it's going to be delivered. But the government have now been at this for 10 months and it was a manifesto commitment. Could she give a commitment at least to when this target is likely to be set by? Because nothing's going to happen until this process reaches a target and then the plan is put in place. And so women are waiting all the while the government are spending time deciding when to make a target.
I thank the Shadow Minister for an intervention. We are working at pace and we are making sure that what we do is right and making sure that it is achievable. Madam Chair, you will be aware that the government is developing a 10-year plan for health, and women's health, including maternity health, will be at the centre of that. And we want to make sure that whatever we put in place dovetails with all of the other interventions and actions that this government is putting forward. The areas identified to focus interventions around, which we have done so far, include improper management of existing conditions, racism and discrimination, and access to care. We're clear that we want to see innovative and high-impact ideas that will really shift the dial. We want to make sure that we're not just coming up with some sort of plan, but that we're making sure that the plan can be delivered and will be impactful. Let me assure my honourable friend that this issue keeps us up at night, and I know that she will continue holding us to account. Madam Chair, I began my speech by referencing Amber's story. She asked how she could put her trust in a system that let her down so badly, and I completely understand why she felt that way. It's our duty to make sure that women like Amber can trust the system with something as precious as their children, and to prevent what should be one of the most joyful days in their lives from becoming a tragedy. Thank you.
Ribeiro, Adi, to wind up, please.
Thank you very much, Chair. And I'd like to thank all of the members present for this afternoon's debate and for all of your thoughtful and very well-balanced contributions. It's not very often in this House that we're generally in agreement, and so I'm always heartened when we have this particular debate, because I'm joined by members from different political backgrounds who actually come together and call for us to do more to improve the state of maternity care. I was very grateful for interventions from my honourable friend, the member for Manchester Rushholm, talking about the lack of spaces where black women feel supported and the importance of increasing those for all women in maternity care. And my honourable friend, the member for Croydon East, pointing out the need for a national target and a national framework to challenge these issues. And my honourable friend, the member for Sherwood Forest, and the chair of the maternity APPG, with her fantastic speech on the significant concerns that are being raised on the quality of safety and maternity services in Nottingham University Hospital, and the very important points she made on tackling the underlying issues of culture within the NHS. I was also very pleased to hear from the honourable member for Chichester and the Liberal Democrat spokesperson rightfully pointing out that this disparity is a national scandal. And you know that we're at risk of normalising these issues, and I think it's so important that we continue to challenge them. And whilst I don't agree with my with the honourable member from the opposition on much, she did raise a very good point about language services, which I think was quite key. I'd also like to thank the Minister for her response and for detailing the steps that the government is taking to tackle this. I know the government have committed to setting a target to end racial disparities in maternity care, and I was really pleased to see it as a manifesto commitment. But at times it can be hard to feel as if the issue is being kicked in long grass when the target hasn't yet been set. So we're looking forward to that. And, you know, there are several campaigners that will be watching this debate this afternoon who would have really rejoiced when they heard that the government committed to setting a target, but who are, like me, continuing to wait in eager anticipation to hear what it is. So I hope the Minister will take that on board and that we won't be waiting too much longer for the target to be announced. Also, I wanted to add that should there be a national inquiry into maternity services, we would hope that black maternal health would be considered as a very clear element of this, with standalone recommendations on what should be done to tackle these disparities. That would be extremely important. And I also want to thank, in particular, the Minister for actually acknowledging the need for anti-racist training, acknowledging that systemic racism exists, and acknowledging that, you know, there are various things that we have to do. I think one of the worst things that can happen, particularly to women in this situation, is when they're gaslit into thinking that the experiences that they have just did not happen. It's so important to acknowledge that these things and the fact that they are not listened to purely because of what they look like, where they are from, their ethnic origin is causing so many problems, actually leading to deaths. So it's important that we acknowledge them, and it's important that instead of burying our heads in the sand, that we actually tackle these issues of racism and discrimination in our health service. And I want to say finally to all of the campaigners who are listening to the debate today, I want to thank you all again for your hard work and tireless campaigning. I know many of the women involved in this campaign have gotten involved because of their own experiences in maternity care or because of the experience of a loved one. And many of those who have dedicated their time campaigning on this issue are doing it because they don't want anybody else to go through what they went through. I know it can be really exhausting to relive past traumas and to continue to push the cause, but it's through your hard work that we're having this debate today, and it's through your hard work that we have a government that's actually willing to address these issues. In my open remarks, I mentioned the worrying findings from the recent Embrace UK report, which revealed that the overall maternal death rate is increasing, which is outrageous, and this should be alarming to all of us that hear it, but it should spur us into action. For as often as I say each time we have this debate, improving the state of maternity care for black and ethnic minority women and babies will actually improve the overall quality of maternity care for all mothers and babies, and I hope we can agree that that is certainly worth doing. Thank you.
The question is that this House has considered Black Maternal Health Week 2025. As many as are of that opinion say aye. Of the contrary, the ayes have it, the ayes have it. Order, order.